कर दीजिए ऑफ।
स्टार्ट करें?
नहीं ऑफ कर ही दीजिए, ये बोल रहे हैं। स्टार्ट करने के तो 5 मिनट रुक जाऊंगी। कर दो स्टार्ट। Good afternoon to all of you. So in today's practical class we'll be discussing a few cases. So you'll be getting a few cases and you should actually try to answer questions based on these cases. These classes are important as in your exams also you get a few cases, you get to write some prescription based on the case, or you write to correct the thing, or you need to write the rationale behind the thing stated in those cases. So you need to be versed with things, and whenever you are seeing any case, any patient or anything, you should think from pharmacological aspect, the rationale of the drugs, the advantages, the disadvantages, the rationale of the combination or drug interactions, etc. So these cases are basically made to prime you on those aspects. So we'll move with our first case. A 50-year-old woman presented in the emergency department with high-grade fever, burning micturition and altered sensorium. After laboratory workup, she is diagnosed with complicated urinary tract infection. Patient was started on parenteral imipenem plus cilastatin and paracetamol. So, I repeat again, a patient, a 50-year-old woman, the presenting complaints are high-grade fever, burning micturition and altered sensorium. So, empirically also you will think of some UTI because fever, burning micturition is there, and then we see there is an added component of altered sensorium. So, and when we do laboratory workup, we diagnose that case as not just urinary tract infection but complicated urinary tract infection. Now you see that the patient was started straight on imipenem plus cilastatin and paracetamol. So imipenem basically is a broad spectrum drug, and it will basically acts on gram-positive loci, but it has a broad spectrum, so it covers Escherichia coli, etc., which is the most important causative agent of UTI in most of the cases. So that is why we started imipenem. Now, because in empirical therapy, in most of the cases we start with broad spectrum drugs. Now you see a second component of cilastatin was added to this imipenem. So what is the rationale of imipenem-cilastatin combination? Now, imipenem has excellent activity against common UTI causing pathogens like E. coli, Klebsiella, Pseudomonas, Enterobacter, etc. I already told you this. The second component of cilastatin, that is added because imipenem is degraded very shortly. So its time of action is very less if it is given alone. So what happens is when combined with cilastatin will inhibit the enzyme dehydropeptidase 1, which is in brush border of the renal tubules. So this enzyme actually metabolizes or degrades imipenem. So, and cilastatin inhibits this renal tubular dehydropeptidase 1. Therefore, when we add cilastatin to imipenem, what happens is the degradation of imipenem is decreased. So it prolongs the action of imipenem, and the excellent activity of imipenem against UTI causing pathogens is seen or is observed for a longer duration of time. Now here you see we have a synergistic combination. So what are synergistic combinations? So the first point is they can be inhibiting enzyme inactivation, as we saw in imipenem cilastatin, or other combination also, piperacillin tazobactam, ceftolozane tazobactam, ceftazidime avibactam. Then what happens is, if the two drugs they act on sequential steps in metabolic pathway, then also they are called synergistic. So one of the examples is cotrimoxazole. Then a third case can be if one of the drug enhances the uptake of other drug. So when you give penicillin or beta-lactams with aminoglycoside or amphotericin B with flucytosine, what happens is the agent, for the former agent beta-lactam or amphotericin B, it acts on the cell wall. So what will happen is it will enhance the absorption or uptake or say entry of the other drug like aminoglycoside or flucytosine into the cell wall of the microbe, and thereby enhancing their action. Now when do you call some combination synergistic? You will call some combination synergistic when the dose of at least one of the drugs is decreased to less than 25% on addition of the other one. So in those cases you call this combination synergistic combinations. Then there could be additive or antagonistic combinations. So if the dose of one of the drug or each of the drug is decreased by 25 to 50%, it will be additive. If it is not decreased by 50% also, then the combination is antagonistic. So you decrease MIC levels at least by 25%. So if you decreased to 25%, you call it synergistic. If not, those combinations are not synergistic. So minimum inhibitory concentration has to reduce if the drug is being given alone or is giving or if they are being given in combinations. So you compare the MIC levels of the drug and then you can decide whether the drugs are synergistic or just additive or antagonistic. Then there could be antagonistic combinations like some bactericidal and bacteriostatic. So in bactericidal plus bacteriostatic combinations, what happens is if the drug has high affinity for bactericidal, if the microbe has high affinity for the bactericidal drug, so what happens is bactericidal drugs generally act on rapidly growing microorganisms, but bacteriostatic drugs, they tend to prolong that growth or basically delay that growth. So if bacteriostatic drug delay the growth, bactericidal drug won't be acting efficiently, and that is why the net effect of the combination will be as that of the bacteriostatic drug, and we won't get benefit of the bactericidal and bacteriostatic. So as you see in beta-lactam with tetracycline or chloramphenicol, that beta-lactam is bactericidal and the other component is bacteriostatic. So what will happen is the net effect will be of bacteriostatic drug and not bactericidal drug. So when combining bactericidal with bacteriostatic, you should be cautious, or rather they should be avoided. Next we move on to our second case. So here you can see Rajiv, 23 years old male, presented to the emergency department with acute onset of seizures and fever. He was diagnosed with meningitis and culture and sensitivity revealed infection with pneumococcus. Now how say the physician or say an intern was there and he prescribed a combination of penicillin G and tetracycline. Now I ask you to comment on this antibiotic regimen. We have discussed enough about the combinations with our previous case. So when I ask you to comment on this antibiotic regimen, the first thing you should keep in mind is patient was diagnosed with meningitis and then culture and sensitivity revealed pneumococcus. So the drugs you are giving should be actually sensitive against pneumococcus. The second thing is that the combination you are giving, penicillin G and tetracycline, are they compatible with each other? So is this a rational combination? And if it is, why is it a rational combination? If it is not, why not is it a rational combination? So penicillin G is cidal and tetracycline is a static antibiotic. Now you chose the drugs, say you chose penicillin G very intelligently, because penicillin G is highly sensitive to pneumococcus is highly sensitive to penicillin G. But when you apply that logic, what you see is, as pneumococcus is highly sensitive to penicillin G will act on the rapidly growing bacteria, the growth phase basically. But what will tetracycline do? Now it will halt the growth. It will try to delay the growth basically. So in that case, what will happen is you won't have effect of penicillin G, but rather than only tetracycline. So this is not a rational combination. Now if you think about, if I ask you any such other combinations if that should be avoided, then you can think of penicillin G and erythromycin for group A streptococcus. Now for the similar reasons that penicillin G or group A Streptococcus is highly sensitive to penicillin G, and erythromycin is a static drug. So what will happen is the effect will be of erythromycin and not of the combination. Same here with nalidixic acid and nitrofurantoin. Again, nalidixic acid will be bactericidal and nitrofurantoin bacteriostatic. So these will produce actually an antagonistic combination rather than synergistic. We try to achieve at least additive effect. We actually want to achieve a synergistic effect, but then at least additive is fine. But antagonistic effect, of course, we don't want to achieve. So these are actually not rational combinations. So here, what are the bacteriostatic antimicrobials? Tetracyclines, chloramphenicol, macrolides, sulfonamides and clindamycin. These are bacteriostatic. And bactericidal are aminoglycosides, beta-lactam antibiotics, rifampin, quinolones, glycopeptide antibiotics. And the bactericidal drugs, they tend to act on the rapid growing phase, or rather the growth phase. This is just, you all actually know all these things. I'm just recapitulating, just that you will revise things and you can actually reproduce that when asked a question in your exam. Next we have our case as a 25-year-old newly married woman, Mamta, with history of head injury 1 year back, visits neurology OPD with complaints of 2 seizure episodes in last 3 days. She has no family history for any seizure disorder. After investigations including EEG and MRI, diagnosis of tonic-clonic seizure disorder was made. Now, what are the anti-epileptic drugs that can be considered for this patient? So if you just see that there is a patient, a 25-year-old woman who has tonic-clonic seizures, then you might actually give a broad range of drug, most of the drugs basically, whichever you have read in your anti-seizure classes or epileptic classes, you can actually you mention those. Then the second question comes as monotherapy or multiple anti-epileptic agents. So first we'll start with monotherapy, and then if we see the seizures are not controlled, then we add on the second drug, or then we add second drug, and if that also does not work, if we have had trial of 2 drugs for sufficient duration of time, then we render that patient as drug refractory or drug resistant epilepsy, and then we go on for other modalities of treatment as well, say some nerve stimulations. Then now again I'll tell you to read that question again when you see a 25-year-old newly married woman, Mamta, with history of head injury. So a newly married woman is most likely to be on some of the measures for, say, contraceptives, some of the measures for birth control. So now if the patient is on contraceptives, say a combination pill, an estrogen plus progesterone combination, now I ask you the question, why the following anti-epileptic drugs are not suitable for this patient? Phenobarbital or phenytoin or valproic acid. Now, our combination pills, they contain estrogen plus progesterone, we all know that, and estrogen, the estrogen component, that is metabolized by CYP3A4. Now, anti-epileptic drugs, the phenytoin is most commonly, it is known to induce CYP3A4. So what will happen when these enzymes, the cytochromes, these are we give some enzyme inducer along with them, what will happen is that they will increase metabolism of the substrate. So if there is increased metabolism of the substrate or the substrate drug, what will happen? Its action will deteriorate. Now in this case we are giving estrogen. So what will happen is CYP3A4 will lead to increased metabolism of estrogens, and it may lead to contraceptive failure. So what do you require? What do you require of the patient? So we require the patient to use some alternative method of contraception, such as some barrier contraceptives if they are on anti-epileptic drugs, because these are basically the most common choices if we have to choose for some generalized tonic-clonic seizure for a patient. We are more likely to choose any of these, phenobarbital or phenytoin and valproic. So if we have chosen any of these, and side by side the patient is also taking some combined pills for birth control, then what will happen is the patient will there will be contraceptive failure, and to prevent that, or to prevent an unwanted pregnancy, we should suggest an alternative method such as some barrier method of contraception. Moving on to our fourth case, a 30-year-old female, Radha, weight 60 kg, presented to outpatient department with fever, with symptoms of fever on and off, headache and abdominal pain for past 10 days. Now, what did the physician do? He must have done many tests, but then when he did Vidal test, Vidal was found to be positive. Now, patient was started on antibiotic for typhoid fever. Comment on the prescription. So here I actually want to emphasize that you should actually take tips for writing prescription also here, because you get prescriptions in your exam, and most of the times we see many of the important components of prescriptions are missing actually. So you see name of the doctor, that should be mentioned, a registration number, that is to be mentioned, date is to be mentioned, name, age, gender of the patient, address, these should be mentioned actually in superscription. Then you have to write the main prescription. Now it's okay, the format should be correct, as well as when you write prescription, that should be correct pharmacologically. Means you should know the rationale of the drugs you are writing. You should know the actual drugs or the drugs of choices basically to be given in those conditions, and that should be mentioned here. It's not that you can mention anything. And when we give you prescriptions to correct, we also we might make mistakes, that of course deliberate mistakes for you to correct. That could be in any part, that could be in superscription, that could be in inscription, that could be in subscription of the prescription. Now apart from superscription and inscription, that is the main body, you should of course write, means you should have signature at the end of every prescription, and most of the time signature and stamp have to be present. But in your exams you should keep in mind that you have written correct superscription, correct inscription, and of course if there are some additional advices to be given to the patient for the drugs you are mentioning, or some lifestyle changes, anything, that should also be mentioned as advices at the end of the prescription. So now I have shown you this prescription. You see superscription is correct. They have written name of the doctor, the hospital, registration number is mentioned. When we come to inscription part, you see we have written tablet amoxicillin 500 milligram thrice a day for 5 days, and paracetamol 500 milligram SOS. So what do you think? Means if we get a confirmed case of enteric fever, should we start with amoxicillin or do we prescribe amoxicillin? No, of course not. So now what we have to correct is, we have to correct the inscription part first. So you see we have written tablet cefixime 200 milligrams orally twice daily for 10 days, and paracetamol 500 milligram orally for 3 days, 4 times a day. So you see we have written the drug, the doses which we have to give, the frequency and the duration. All the things have been mentioned in this prescription. Below your main inscription part, you see we have written some advices for the patient. So avoid spicy and oily foods, plenty of fluids, then review if symptoms don't subside or worsen. because in many of the cases, especially in some infectious diseases, what happens is the patient is already resistant to some of the drugs. So it's not that if I have given a drug for 10 days, that should be continued for 10 days. If the patient does not feel like, or the patient has some say some progression in the disease, or the drug is not working on him, he can always come back to the person or the physician. So we should actually write this line of review. If symptoms don't subside, then we have a signature at the end. So for empirical therapy of enteric fever, we have ceftriaxone 2 gram per day IV, duration would be 10 to 14 days, or we can give the patient azithromycin 1 gram per day per orally for 5 days. For the patients who are fully susceptible to the first line drugs or the drugs of choice, optimal therapy is ciprofloxacin or ofloxacin, and alternatively we can give azithromycin to the patient. Then if the patient is resistant, so in those cases, most of the cases you see nowadays are actually resistant to ciprofloxacin. So what do you give to them? For them we prescribe ceftriaxone or cefotaxime or cefixime. So if you are giving ceftriaxone or cefotaxime, you have to give it IV or IM, and if you are giving cefixime, you can get a oral formulation, so you can give them as tablets. Alternatively, you can try ciprofloxacin. So in this prescription of ours, we have chosen oral drug, so we give the patient tablet cefixime 200 milligram orally twice daily. If the patient was not able to take orally, patient has some altered sensorium or had some severe disease, what would we do? We'll give him some parenteral preparations and we'll try to give ceftriaxone or cefotaxime. So when you are writing prescriptions, try to write rational drugs. You should write drugs of choice basically, and then try to make your prescription as rational as possible. Now next cases will be taken by Dr. Shashika.
Good afternoon everyone. So we have seen some of the cases. So questions like these can be asked in your practical exams in the form of your spot exercises or in the form of some short exercises also, or they can be asked in your vivas also, questions like these, and the theoretical part of these questions or the part which is related to your core pharmacology can be asked in your theory exams also in one way or the another. Okay, so just pay attention to these exercises. Such questions can be asked from any chapter. Okay, so just like some of the previous cases, consider a case of a 28-year-old female who comes in the emergency department with complaint of intense migraine headache. Which of the following drug is the preferred drug for this patient? So when we read about the drugs which are used in migraine, you read around 10-12 drugs which are given there in your textbook. Okay, but not all the drugs are prescribed for any patients, and we always have to make a choice between which drug is suitable for a particular case. So that is the case when we read about something in the textbook and when we apply that knowledge in our actual clinical use. Okay, so like in this case we have all these drugs: butorphanol, paracetamol, sumatriptan, diclofenac, ergotamine, propranolol. These all have been given in your textbook, right? But in a particular case, only one or two of these drugs can be used, right? So just to give you some background, butorphanol belongs to opioid class of drug. It's a partial agonist, antagonist, acts on mu receptors and kappa receptor. Paracetamol, diclofenac, they belong to NSAID group of drug. Ergotamine is an ergot alkaloid. Sumatriptan is a serotonergic drug. Propranolol is a beta blocker. But they all belong to, or they all can be used in case of migraine headache. But here in this particular case, the patient is coming in the emergency. Patient is a young female who is coming in the emergency department. Okay, and she is having intense migraine headache. So first, the therapeutic objective in this particular case is to relieve the patient of the pain. So from the drugs given, butorphanol, paracetamol, sumatriptan, diclofenac, ergotamine. All these 5 drugs can be given for acute migraine headache. Propranolol cannot be given because it is used for it is used in severe migraine, but it is used for prophylaxis of migraine headache. Okay, so we have to choose the drugs among the top 5 drugs, right? Among butorphanol, paracetamol, sumatriptan, diclofenac and ergotamine. Now here again, for acute migraine headache, most effective drug is usually your serotonergic drug, which is your triptan group of drugs, right? So that is why you may read a line like in your textbook like sumatriptans are the drug of choice for acute migraine headache. So they are the most effective drug to relieve the pain of migraine headache. NSAIDs can also be given for acute attack, acute migraine pain, but again diclofenac is a NSAIDs which acts mostly peripherally, and it is more of an anti-inflammatory than analgesic drug. Okay, so that is why if it is a mild pain, then paracetamol may be used, but if it's a severe pain, then sumatriptan are considered the first choice drug for any patient. Again, ergots are also considered very effective for relieving acute migraine pain, but they have an issue of erratic oral bioavailability and nausea, other gastrointestinal side effects, because of which sumatriptan are considered, or the triptan group of drugs are considered more appropriate to be used in acute migraine pain. Okay, so this is how in every clinical scenario you already have read about different drugs or different class of drugs which can be used, but you already have to decide depending upon the scenario in which the patient is presenting one of the drug. Okay, so so we have ruled out paracetamol and diclofenac, and we have preferred sumatriptan, ergotamine. Opioids are also very good analgesics, but we are not considering it in this particular case. The reason is they are analgesics, but butorphanol is actually an injectable drug. So one thing which goes against it, it is not studied that well in human population. It is definitely used in animals as a very good analgesics, but especially by oral route. In humans it is used only as an injectable or intranasal preparations, but again it is not that efficacious in relieving the pain of migraine like in case of these triptans, because if you go back to the pathophysiology of migraine headache, it is basically related to spasmodic vasodilatation in the cranial blood vessels. Butorphanol, although it acts directly in the central nervous system and the pain centers and relieve and shows its analgesic activity, but the core pathophysiology, which is the vasodilatation in the cranial vessels, only triptans and ergotamines, they act on that side. Okay, so that is why they are more effective in directly acting on that side. Okay, so from these drugs, which of these will you prefer if the patient is also having a history of CAD, the coronary artery disease? Then we'll have to go to butorphanol. See, coronary artery disease is again a contraindications for all the drugs, all the ergot alkaloids as well as your triptan group of drugs, because they inherently have this property of causing vasoconstriction. Okay, so they are relieving the pain of migraine by causing or by treating the cranial blood vessel vasodilatation, but they are also causing vasoconstriction in the cardiac and other cardiac blood vessels. Thereby they have a risk of precipitating angina and other coronary artery disease. So in that case we will not consider using the triptans as well as the ergot group of drugs. And if the patient since the patient is already a 28-year-old female, so before starting or before giving any ergot or any triptan group of drug, you will also have to rule out a whether the patient is pregnant or not. Okay, because these triptans and the ergots, they are contraindicated in pregnancy. Okay. Similarly, if the patient says that she had headache last night but she is relieved now, okay, she is coming in the OPD and she says that she had a very severe headache last night but she is relieved of the headache right now in the OPD. Okay, so and she says that she had this episode of severe headache 4 or 5 times in the last month. So then it becomes a case of severe migraine, and you have, apart from treating the acute headache, you also have to take care of the some prophylaxis treatment so that to prevent this recurrent headache. Okay, so in that case, as a prophylaxis, you will have to give some propranolol. Okay, so this is how you select a drug among all the drugs which you know can be given in a particular disease, right? Take this another case of a 28-year-old male who was receiving phenytoin 300 mg daily for generalized tonic-clonic seizures, and symptoms were controlled. Patient subsequently was diagnosed with tuberculosis and was prescribed HRZD treatment. Now reports to his treating physician with seizure recurrence. Explain the likely mechanism. Now see, these are not just some theoretical exercises which have been made by just permutation combination combining these drugs. These are very much these scenarios are very much common in our routine practice also. Like this conditions like epilepsy, tuberculosis. Tuberculosis is anyway very highly prevalent in our country, and any other chronic conditions, be it some epilepsy or conditions like diabetes or hypertension, they are also very commonly encountered chronic conditions which patient give history that they are also they already have these diseases as some background disease. They may be having some acute illness in the form of some infection or anything like that, but they already have something diagnosed. Okay, so these concomitant illnesses or the drugs which they are receiving for those concomitant illnesses, they may give us a condition wherein there is some possible interaction between the drugs, and that you have to take into account while prescribing or while evaluating the patient. So like in this patient, the patient was already diagnosed case of GTCS, was already receiving phenytoin, and now he was diagnosed with tuberculosis and was already taking HRZD treatment. And while on HRZD treatment, he had this seizure recurrence. So this is a very easy to guess interaction. The rifampicin, being a cytochrome inducer, enzyme inducer, it decreases the plasma level of phenytoin, which leads to poor seizure control. Okay, so this can happen with both rifampicin as well as isoniazid. Serum phenytoin levels may fall in patients who are fast acetylators of isoniazid and may occasionally rise in those who are slow acetylators. You already know this acetylation concept. This acetylation, it shows some genetic heterogeneity in population in general. They can be fast acetylator and slow acetylators, and thereby metabolism of isoniazid can vary in the population. Okay, so interactions like these you have to take into account. This another case of patient who is a 45-year-old gentleman who has come to OPD with chief complaints of tremor in his fingers for past few months. Also noticed his walk has become slow and body is more rigid than usual. Detailed history, find out that there is no other comorbidity, not taking any other medication, and there is no family history of similar illness. On examination, notice resting tremors, shuffling gait and decreased facial expression. Provisional diagnosis of Parkinson's disease is made and some prescription is given. Now such kind of exercises are again asked in your some ultra short exercises in the practicals also, that you will be given some prescription which has some errors. You have to find out the errors, correct it, and then rewrite the prescription. So the mistakes can be in the formatting of the prescription which has been written. You have to check whether it has as already told in the previous sections, previous questions, whether it fulfills all the part, like it has the superscription, subscription, signature, dose, frequency, duration, the patient detail, doctor's detail, everything has been written, or there can be some error in the form of the choice of drug which has been given or the dose which has been given, something like that. So you have to take note of everything, okay, and then comment upon the prescription. So like in this case, Parkinson's disease is the diagnosis, patient name is written, patient details can be further elaborated, doctor's details are missing, signature is missing, so these are all related to the format of the prescription, which is erroneous in this particular case. Now coming to the drug part, the patient was given carbidopa, levodopa, entacapone. For 21 days it has been given, for 7 days it has been given, since the dosage is thrice daily. Rasagiline is given once daily in the morning, pyridoxine 40 mg, 1 tablet orally once daily. Now pyridoxine, again this is very straightforward error which you can point out, that pyridoxine has an interaction with these drugs which are used in Parkinson's disease, that is, it is a cofactor for dopa decarboxylase, and it increases peripheral metabolism of these drugs, this levodopa basically. So by increasing peripheral metabolism of dopamine, it decreases the amount of dopamine which is reaching in the central nervous system, which is actually its site of action. So pyridoxine should not be used. Now here in this case, pyridoxine has been erroneously prescribed, but pyridoxine is something, it is very commonly present in your many multivitamin tablets also. So here the important thing to notice is that in the patients in any patient, especially in the elderly population, you always have to take some medication history, what medication patient is taking. This may be some nutrition supplement or some other medications which are not prescribed anyways to the patients by any doctor, but the patient is anyways taking it from over the counter or as a self medication. So although it sounds very pyridoxine as such, it's being a part of a multivitamin tablet, it may sound that it is harmless, but in this particular case it is responsible for kind of failure of the treatment which has been prescribed to the patient. So that is why it is important to take proper medication history. You can not just looking back at the previous prescriptions, you also have to proactively ask whether patient is self-medicating with some drugs or not. So patient was prescribed follow-up after 7 days. The correct prescription becomes, you have to complete the patient details, age, gender, weight, that has to be address, that has to be written, doctor's detail has to be completed, and signature and stamp all should be there. Another thing, we have omitted pyridoxine, and then we have to give some advice also which are relevant in this particular case, like patient need to be told that he should avoid taking protein rich diet. Protein rich diet, that decreases absorption of this levodopa, carbidopa, as well as that decreases the drug which enters from peripheral circulation to and crosses the blood-brain barrier. Similarly, we have to tell patient not to take cheese and wine. What is the relevance of this instruction? So you all have heard about this term serotonin syndrome, or the cheese reactions, or this neuroleptic syndrome, which are very much similar clinically. But what happens in these cases is that there is some sudden increase in the circulating this monoamines. Monoamines means your serotonin, it can be serotonin, it can be dopamine, it can be epinephrine, norepinephrine, which are which are physiologically present in the circulation, but sudden elevation in their levels, it can have grave clinical implications. Okay, so this cheese and wine, these contains basically tyramine, which basically belongs to indirectly acting sympathomimetics class, and it indirectly increases levels of these monoamines. And now the patient, we have already prescribed patient drugs like entacapone and rasagiline, which are COMT inhibitors and MAO inhibitors. So they are the drugs which are inhibiting metabolism of these monoamines. So thereby there is always a risk that these monoamines, their level may accidentally increase because we have given supplemented with tyramine, as well as we are giving the enzyme inhibitors. So that is why if the patient is already on these MAO inhibitors and he is also taking this cheese and wine, he may land up into this life-threatening condition which is known as cheese reaction. Okay. So these instructions become an important part of prescription, which you always remember. Like if you are given a case of, say, some a very not some emergency. If you are asked to prescribe for a patient of hypertension, you are following all the guidelines and you are prescribing ACE inhibitors or beta blocker or whatever you consider suitable for the patient. You are prescribed for the patient. But in that case also, advising patient about salt restriction is very important, because it is already known that this lifestyle modification, they have an important role to play as a part of treatment for the patient. So these advice or these instructions, which are not as such a part of the pharmacological treatment, but they are very much important as a part of your prescription. So always take note of these things, especially for common illnesses which you encounter in day-to-day practice, like Parkinson's, hypertension, diabetes, tuberculosis, asthma, and do remember these instructions to while writing the prescription for these diseases. Now there is another case where something similar. 42-year-old man has been diagnosed with Parkinson's disease previous month and has been taking carbidopa, levodopa and entacapone 3 times daily. The dose has been given. Selagiline also is prescribed to the patient. He is recently started on tablet fluoxetine 20 mg once daily for depression. Again, this is not another mix and match case. Parkinson's disease or these neurodegenerative conditions very commonly have this psychiatric component to it, and they may have these symptoms related to mood disorders or depression, like that. So he's also been prescribed fluoxetine. It can be prescribed. Now another possible reason is that the physician who is treating the Parkinson's disease, he may be some neurologist. He'll take care of the drug for Parkinson's disease, and he'll prescribe according to that. He may not be aware of other component of his illness, like depression in this case, and that may be treated. Patient may be taking treatment for that from some other psychiatrist. So he was already taking fluoxetine, and now he was being prescribed this drugs for Parkinson's disease. Now he attended a wedding reception, and in the middle of the event he brought to the emergency with chief complaints of sudden onset of anxiety, confusion and agitation. Vital signs revealed increased temperature, increased pulse and tremor. Neurological examination revealed myoclonus and hyperreflexia. So what is the possible diagnosis? So here again, especially when you see such cases in your exams or in such case question you see in an exam or anywhere else, just take note of, mostly when we see these drugs, MAO inhibitors or COMT inhibitors, there are good chances that it's a case related to cheese reaction or serotonin syndrome, something like that. Okay, but this is some drug interaction which is kind of a life-threatening emergency for the patient. So it is actually very important to timely recognize these, timely diagnose this drug interaction. So this particularly is a case of a serotonin syndrome. The patient is being prescribed fluoxetine and is already taking MAO inhibitor. Okay, so this selagiline also inhibits the metabolism of serotonin. Fluoxetine is a SSRI, which by inhibiting the uptake of serotonin, it is increasing levels of serotonin in the synaptic cleft. But since the patient is already taking MAO inhibitors, so the levels of serotonin may be that much to cause this life-threatening emergency of serotonin syndrome in the patient. What precaution could have prevented this condition? So just we'll see what is this serotonin syndrome. As I already told you, fluoxetine is a SSRI, interacts with selagiline and led to serotonin syndrome, which may manifest as sudden onset anxiety, confusion, agitation, increased temperature, increased pulse, tremor, myoclonus, hyperreflexia. because of increased serotonin. So this clinical scenario is very much similar to what we see in cheese reaction, but here, since there is no history of cheese and wine intake, so this will not be come in under the cheese reaction. Although in cheese reaction also the principal pathophysiology is because of increased monoamines only. Okay, so the basic underlying pathophysiology is similar in both the cases, but they are two different conditions. Also, these atypical antipsychotics such as clozapine, olanzapine, risperidone, they should be used for depression in Parkinson's disease for the same reason, and the otherwise commonly used antidepressants like the SSRI or the SNRI, they should be avoided in these in Parkinson's disease particularly, especially when the patient is already taking these MAO-B inhibitors. Okay. It's a potentially life-threatening condition with increased serotonergic activity in CNS. It has a triad of mental status change, autonomic hyperactivity, and neuromuscular abnormalities. The underlying exact pathophysiology is still poorly understood, but it is said that it is because of postsynaptic HT1A and HT2A receptor stimulation, and the majority of cases present within 24 hours, and most within hours the patient manifests all these clinical features. So now differentiating this serotonin syndrome with another clinically similar scenario of neuroleptic malignant syndrome, which is this neuroleptic malignant syndrome is basically seen with the antipsychotics. Okay, and this serotonin syndrome is basically seen with the drugs which modulates the level of your monoamines in the form of serotonin, SSRIs or MAO inhibitors. Here we see this serotonin syndrome. There are certain differences in the clinical features of these two conditions also, like serotonin syndrome presents within hours, whereas this neuroleptic malignant syndrome, it takes some days or weeks to manifest. In terms of neuromuscular findings, there are hyperactivity in case of serotonin syndrome, whereas it's bradyreflexia and severe muscular rigidity in case of neuroleptic malignant syndrome. Causative agent is serotonin agonist in case of serotonin syndrome, whereas it's dopamine blockade in neuroleptic malignant syndrome. Talking about the treatment of these two conditions in serotonin syndrome, since it's an emergency, it's manifesting within hours. So the main therapeutic goal here is to first decrease the hyperexcitability or hyperstimulation of central nervous system which is there in the patient. So in serotonin syndrome, the most important drugs are the benzodiazepines, so as to sedate the patient. And since there is a hyperstimulation of serotonergic receptors, ciproheptadine is also used. Whereas in case of neuroleptic malignant syndrome, which manifests while increasing the dose of typical antipsychotics or while switching these typical antipsychotics, so in that case, since the basic underlying pathophysiology is blocking of dopamine receptors, so the more important treatment becomes the giving some dopamine agonist. So we give bromocriptine for that. And resolution, so serotonin syndrome, it appears quickly, and if treated appropriately, it resolves also relatively earlier in comparison to neuroleptic malignant syndrome. Okay, so other similar features can be in the form of anticholinergic toxicity, malignant hyperthermia, which is seen with case of halothane. You already know this about malignant hyperthermia. Dantrolene is used for this. Okay, and it also shows some genetic predisposition. So talking about management of serotonergic syndrome, discontinuation of all serotonergic agents, supportive care aimed at normalization of vital signs, sedation with benzodiazepines, administration of serotonin antagonists, and then assessment for the need to resume use of causative serotonergic agents after resolution of symptoms. Okay, as such, if the patient is having psychiatric illness like depressions, or if SSRIs or SNRIs indicated, we may have to think about some other alternatives which can be used instead of those drugs. Okay. Like in this particular case, since patient had depressive symptoms, So atypical antipsychotics, some of the atypical antipsychotics could have been also used. Some of the drugs which causes serotonin syndrome. The serotonin syndrome is basically because of elevated serotonin levels. So it can be because of increase in release, as happens in case of amphetamines and some drug abuse like ecstasy, or because of impaired reuptake, like happens with SSRI, SNRI, some of the opioids, tricyclic antidepressants. Inhibition in metabolism, like happens with MAO inhibitors. Direct agonist, like happens with triptans, fentanyl, ergot derivatives. Or increased sensitivity of postsynaptic receptor, which sometimes happens with lithium. Now this is the last case. A 60-year-old male with history of COPD, depression and diabetes, who's presented to emergency with acute urinary retention. Now multiple comorbidities are there, very much possible it's elderly patients, and some very commonly encountered illnesses are there: COPD, depression and diabetes. So you can already guess that the patient must be taking multiple medications. Okay. History revealed the patient had frequently taken inhaled salbutamol plus ipratropium dibromide for its COPD exacerbation in the early morning that day. Okay. Underlying medications patient was taking was metformin, glimepiride, atorvastatin and amitriptyline. Okay, what is the cause of urinary retention in the patient? Now you can see this metformin being the first line drug for any diabetic patients. So metformin and glimepiride must be prescribed to the patient for underlying diabetes. And nowadays this in high risk CAD patients, statins are also commonly prescribed. Amitriptyline must be prescribed for depression patients. It's a TCA group of drug. So now patient was already taking these 4 drugs, and since he had this history of COPD, so as given in the question, patient has recently taken multiple times salbutamol ipratropium. Now a patient presented in the emergency with acute urinary retention. So most of the time urinary retentions can have anatomical cause in the form of some urinary stone, or it can be because of some, since it's an elderly male, BHP or benign hyperplasia of prostate can also be there. So anatomical cause can also be there, that has to be ruled out. And in addition, medical cause or drug related acute urinary retention can also be there. More so in this case because the patient is has multiple diseases and is taking multiple medication. So that you have to take into account, that the patient was already taking multiple medications, so there may be some possible drug interactions which are manifesting as acute urinary retention. So here in this particular case, TCAs, this amitriptyline, which have very common anticholinergic side effects, are very commonly known or very infamous for causing these side effects, especially in elderly population of this acute urinary retention. Okay, so amitriptyline being a TCA, tricyclic antidepressants, since they are known to cause anticholinergic side effects, so it is very much possible that it's because patient was taking this anticholinergic already, and now the patient has also taken ipratropium bromide. Although patient is taking it by inhalational route, but since the patient is giving history that he had taken it multiple times, so it is very much possible that this because of anticholinergic overdose in the form of ipratropium, as well as because the patient was already taking amitriptyline, it may have manifested as acute urinary retention. Okay. As such, for acute management, just need to investigate the patient for any anatomical cause in the form. You can get some ultrasonography done, just insert an urinary catheter, relieve the patient of acute urinary retention, get USG done. You can rule out any any stone or any obstruction in the urinary tract. You can rule out prostate enlargement, and by the time you can also stop these medication which you suspect that might be contributing to the acute urinary retention. That is, you can ask patient to withhold amitriptyline for some time and avoid ipratropium. That this much treatment, if it is because of some drug related acute urinary retention, it will get relieved by withholding these drug overdose. Okay. So it was anticholinergic toxicity due to concurrent administration of amitriptyline and ipprotropium bromide. So withholding these drugs would have relieved the patient of the urinary tension. So just like that, you will be asked questions or given some case scenarios. The case scenario, the questions can be related to some format, like correcting the prescription, something like that, or it can have some core pharmacology component in the form of correcting the drug, identifying some drug interaction, or commenting about some treatment of that drug interaction, or some questions related to that. Okay. So while reading about these drugs or some other pharmacokinetic, pharmacodynamic aspect of these drugs, just pay attention to these aspects also. They can be asked in the form of some case scenario also. So if you have any question, you can put up in the chat box. Thank you.
हाँ जी मैडम, हो गया जी खत्म।